So respiratory treatments. The first respiratory treatment, which applies to almost the airway problems, is pursed lip breathing. Please pay attention to this. NCLEX loves it so much. So, what is pursed lip breathing? Pursed lip breathing, we're talking about you inhaling slowly through your nose, at least for 2 seconds, and then you purse your lips as if you are blowing out a candle. So that is what we call pursing. But this time around, your nose is going to be, you're going to breathe through your mouth this time around slowly. So exhale slowly and gently through pursed lip for at least 4 seconds through your mouth. Then you keep this. I mean, what's the rationale for this? The main reason why we do pursed lip is just to keep the airway open. I've seen questions where they are asking you the purpose of pursing. It's not to clear the secretions, it's just to keep the airway open. Once you purse your lip, it increases pressure in the pulmonary system, and therefore the airways will going to open up. This is usually good for emphysema, and whenever you see emphysema, you know that COPD can be part of it, especially COPD. We say that bronchitis and COPD, these are the ones that bronchitis and um, emphysema together, they form the COPD. Don't forget that. Then, if the person is having shortness of breath, they are having anxiety. These are some of the things, or you see in a question called dyspnea, which is difficulty breathing. So these are some of the things that I want you to understand as far as pursed breathing is concerned. Like I said, please don't memorize any of these things. Just understand what pursed breathing is. And if you identify that the problem that is presented to you is an airway problem, then we want to open the air. Do not confuse the opening of the airways with that of clearing secretion. With pursed lip, you are going to open the airways, especially the alveoli. So it is not to clear secretion. If it comes to secretion, we'll talk about that later. I hope by now you understand what pursed lip breathing is. The next one I'm going to talk about is diaphragmatic breathing, like as the name suggests. Think about the diaphragm. So you are going to use the diaphragm. The pressure, the focus is on the diaphragm, which is usually the belly. So use the diaphragm instead of your accessory muscles. So you'll not be using your accessory muscles. That's muscles, especially in the chest. You'll be using the belly um, muscles. So this exercise helps the patient to relax. And usually when the patient, you're going to do diaphragmatic breathing, please don't forget, usually the supine position or sometimes semi-fowler position is the best options for them. Now with pursed, they have to be in the semi-fowler position or in the sitting position. Sometimes to the tripod position also help as well. You want to place your hand on the patient's chest and then one on the belly. Now you inhale slowly through your nose, and then this time around you see that your belly will be rising. So the focus is on the belly, and then you see that the chest will rather stays still. So the focus is not the chest. We don't expect the chest to be rising as far as diaphragmatic breathing is concerned. Then you exhale slowly through pursed lip. Remember, you are exhaling through pursed lip, which you already know what pursed lip is. And then you see that as you are exhaling, the abdomen is going to fall. This exercise help enhances the diaphragm movement, resulting in the lungs expansion. So this one is to expand the lungs, and that's why it's very, very important you know what diaphragmatic breathing is. It's almost similar to that of the pursed lip that we already explained, but this time round we are focusing on the abdomen, especially we're looking at also the diaphragm as well. The two will all help expand the lungs. We want to open the airways. So indications, like I said, these are the airway problems, COPD, stress, pain management. We also use this as well. But as far as the respiratory system is concerned, I want you to focus on COPD. Next is what called the half coffin, as the name suggests. Ha, ha, ha. Say the word ha. So half coffin. So this is the cough, and when we are coughing, this time around we are trying to clear secretion. So we open the airways by clearing secretion. So the first two, we're trying to bring out the trapped air that is actually trapped either in the alveoli or somewhere in the lungs. But in half puffing, think about clearing the airways. So you'll be hearing. "Ah." Mhm. So half coughing is a forced expiratory technique used to mobilize and clear secretion. Very, very important you understand this terminologies. This is not to without causing any airway collapse, a hard cough, like a hard cough. You take a slow breath, a slow, deep breath in this exercise, and then you hold your breath for at least 2 to 3 seconds. And then after that, you exhale forcefully through with your mouth open, saying the ha sound. So that's what we call the ha coughing. Is just to clear secretions, and clearing the secretion will help with the exchange of gases. So again, if a person has, let's say, any of the airway problems, and it is about secretion and not air being trapped, the best treatment is going to be the half coughing. So don't forget that. So COPD patient, cystic fibrosis, you'll notice that with cystic fibrosis, they're producing a lot of secretion, a lot of mucus. Sometimes it's even very thick. We need to break them down. So half coughing is one, chronic bronchitis. This is where the person is producing a lot of secretion from that inflammation. We need to use the half coughing to be able to clear the secretion. Now, post-op patients with retained secretions, this will also help them. Now, please, in the NCLEX, if the person can cough, let them cough instead of giving them or instead of going to suction them. We always want them to do things by themselves. So these are the indication for half coughing. I hope by now you have a very good understanding of some of these general interventions that we put in place for our patients. The next treatment I'm going to talk about, which you might not, or you might have been, you may be familiar with it, but it's called chest physiotherapy, which is CPT. So when we talk of chest physiotherapy, is nothing but a percussion. That's you are breaking down the secretion. We use vibration to break down the secretion, and this will help bring the secretion out. So when the mucus is very thick, we percuss. That means you'll be I would not call it massaging, but you'll be hitting the chest, gently hitting the chest, and then whilst doing that, sometimes it's just a vibration. As you can see, I'm doing mine, and you can see that, yes. So this will help break the secretions and help, bring the secretions out. Now, remember, when you see this in question, if the patient is having COPD exacerbation, we don't use chest physiotherapy to bring out the secretion. This is just to prevent things from happening. We don't want them to go into exacerbation because at this point, chest physiotherapy will not be our best option. If you have to suction them to clear the secretions, and then later on you can do your chest physiotherapy. So pay attention to the questions. So chest physiotherapy, where we are using vibration or we percuss to break the secretions and then bring them out. Now, so this is one of the ways to also clear secretion. So we have learned two ways to clear secretion, either by coughing or saying the half coughing, and then also chest physiotherapy, which is going to break secretions. All will clear the airways. Please pay attention to this because I'm giving you the treatment options that we have so that when it comes to the disease process, it becomes easy for you. So once you have a disease process where we have secretion, you're not going to be doing partially breathing. You know that now I have to do the coughing, I have to do the chest physiotherapy, and it's applicable to every chronic condition that involve the production of secretion. Now, contraindications. I've seen a couple of questions where they will tell you that, okay, fine, this patient has an order for chest physiotherapy. But then you notice that there are certain things as a nurse, the fact that you have an order doesn't mean that you should be carrying down with the order when there are certain things that are not, um, when certain things are not met or certain conditions or when the patient start changing. For example, when the patient's vital health signs are not stable, chest physiotherapy cannot, we cannot use that when the vital signs are not stable. When there is an increase in intracranial pressure, which I'll talk about a lot when we come to the neurological, you will notice that chest physiotherapy will not be a good option. Bronchial spasms, the person's airways are already closing. This is a medical emergency. We cannot do chest physiotherapy at this point. If the person also have a history of pathological fracture, they have weak bones, or they have deep fractures in the chest, we don't want to mess them up because when you have a fracture and this is healing, it's very difficult to heal bones. So we don't want to break any bone when we are doing this exercise. When they have rib fractures, I already said that. And then also when they have any surgery with incisions, please stay away from this chest physiotherapy. Again, I'm going to make it clear to you, chest physiotherapy is not for emergencies. We use this to prevent when the patient is stable and they have secretions, that's what we do to clear the secretions. All right. Now, with this one, I'm not going to let you focus a lot on that, but when usually you are asked to do it, these are some of the things that you can do. First, to perform chest physiotherapy, we prefer it to be done in the morning or when the person wakes up. That is where you have a lot of secretions built up in the person. Now, to start the chest physiotherapy, make sure that you have at least an hour before meals. And then also, if the person decide to eat, you can also do it 2 to 3 hours after the meals. But don't do it whilst the patient is eating. This is contraindicated, especially when you have a patient with cystic fibrosis. This is a kid. They want to eat breakfast and then they also want to get the chest physiotherapy done, especially when they have the vest. Please do not do that because of the risk of aspiration. Now, we also have to stop the chest physiotherapy when the patient start complaining of pain, especially in the chest, you need to stop right away. If the client is receiving a tube feeding, treat it as well. They are still eating. So what you do is that you are going to stop the feeding, you aspirate for residual before you begin any of your chest physiotherapy. You also, if the patient has medications like bronchodilators, please, you can give them 15 minutes before you start. You want to place a layer of material or gown, or you can put a pajamas also between the hands whilst or between your hands so that you don't put direct pressure on the patient's chest. You can also use percussion devices. This time around, we have them all in the system. You want to position the client this time around for postural drainage based on the assessment. So if the drainage is going to be much easier when they are on the left, why not go it that way? Usually the left side, but hey, depending on what you have, if the problem has to be on the right, check the patient. So always listen to what you have in the question. Don't assume. You want to percuss the area for at least 1 to 2 minutes, and you want to vibrate the same area while the client exhaled 4 to 5 times, to 4 or 5 deep breath. So whilst you're doing it, and then the secretions is coming, they will have to be exhaling, and this all help clear the secretions. You want to monitor for respiratory tolerance. Are they actually tolerating? If they start changing in terms of respiratory, then please stop right away. Stop the procedure if you notice that the patient is becoming cyanotic which is the bluish coloration either on the lips or the fingers, and that you know that this person is lacking oxygen and therefore you have to stop. You want to maintain the position for at least 5 to 20 minutes after the procedure so that they can help clear most of the secretions out. Now repeat in all necessary positions until the client no longer expectorate any mucus. So you want to be moving from different areas until all the secretions are clear. So chest physiotherapy, when we talk of chest physiotherapy, is nothing but breaking down secretion, mucus, which are thick. Especially you see this in patients like cystic fibrosis. If the question says that uh, they have thick secretion and a select order apply, which are the fluid interventions can you put in place? Then you can opt for. If it is cystic fibrosis, yes. If it is COPD and the question says they are having thick secretions, why not? If they are having pneumonia and they are producing thick secretion, why not? They can. So this anything that involves the production of secretions, think about it. So that's why I'm telling you, do not memorize. Just understanding that chest physiotherapy is to help break down the secretion, especially when they are thick. Now, anytime you have these secretions, they may be infectious, so you make sure that you do not just throw them anyhow. Make sure you dispose them, especially put them in a biohazard bag. You also want to provide a mouth care after the procedure. Very, very important. Any questions with chest physiotherapy? So chest physiotherapy is nothing but breaking down secretions, especially when they are very thick and the patient cannot cough them out. We help break them down and then they can bring them out. The next treatment, as far as the respiratory system is concerned, is called the incentive spirometer. The incentive spirometer is used usually to help expand the lungs. And usually the main reason why we give incentive spirometer after surgery is to prevent pneumonia. So let's jump into it. Incentive spirometer. We call it incentive, right? Spirometer. It's not for emergency purposes. Again, please take note of this. It's not for emergency situations. It is when the patient is stable. That is where we can use the incentive spirometer. Now, how do we instruct a patient? You are the RN. You are the one to teach this patient how to what? Use the incentive spirometer. You are the LPN. After the teaching by the RN, you as an LPN can reinforce what the RN has taught the patient. So please, take note of that. We have LPNs, we have RNs, their role. If the question says which of the following can you delegate to the LPN, not the first teaching, they can do the reinforcement of the teaching. So first you ask the clients or instruct the clients to assume a sitting or upright position. The next is that you have to let the client place the mouth tightly around the mouthpiece of the device. After that, you ask the client to inhale. This is where a lot of people make mistakes. People exhale. You do not. You inhale slowly to raise and maintain the flow rate indicator between the target mark, which is usually set by the respiratory therapy. In this case, I'll choose 600 to 900. Again, this number is not fixed. Usually, they'll do the calculations and tell you that this is going to be our mark. So in this case, what you have to do is that tell the patient to inhale slowly, not too fast. The key thing is to help the lungs to expand. So they have to inhale slowly, maintain the flow rate, and then make sure they don't have to exceed the target mark. Next, you instruct the client to hold their breath. Please take note of this for at least 5 seconds. And then they can now exhale. Again, not just exhale, they exhaled through pursed lip. This will help expand the lungs, and usually the alveoli will be opened and bring out all the trapped air. This is how we prevent pneumonia. Where will you see this? In terms of skills, they can ask you to teach the patient. In terms of risk reduction, we are trying to prevent pneumonia. In this case, you can see the question either under risk reductions, you can also see it under the skill section because you are teaching the patient how to what? To use the incentive spirometer. All right. Our last treatment option is going to be mechanical ventilation. Mechanical ventilation usually is our last resort. This is where the patient is not able um, to do that gas exchange anymore. They cannot breathe in, they cannot breathe out. So we let a machine do that for them. That is what we call mechanical ventilator. So we are using a machine to pump in and get rid of the air. That is mechanical ventilator. But most of the questions you'll be having is going to be how you respond to the alarm systems. There are two main alarm systems that are usually tested as far as NCLEX is concerned. The first one is the high pressure alarms. With the high pressure alarms, it's an indication that there is a resistance to the flow of air when the machine is trying to push the air into the patient. What are some of the things that will cause this resistance? One, when we have secretion, if secretions are built up there, then definitely the high pressure alarm will go up. And what will you do as a nurse? If it's a secretion, you start with the least intervention. If they are alert, let them cough. Tell them to cough. They can use a half coughing and then they can bring the secretion out. On the other hand, if they cannot, all you have to do is prepare to suction the patient. But before then, you can also change their position to the left. If that will not help, suction them if needed. But always remember, suction, as far as NCLEX is concerned, is a sterilized technique. You are going in there, so you make sure you wear your PPE. You are more of infection. Think about infection control as far as suctioning is concerned. I have already, we already know how to go about the suctioning. Another thing that can also cause the high pressure alarms to go off is when the person airways are closing and then you start hearing wheezing, or when the person is having spasms, especially in the bronchioles. So this might be the bronchial spasms. Please, airways are closed and therefore there is a resistance to the flow. In this case, you are going to give them a bronchodilator to open the airways. Another one is when the endotracheal tube is being displaced. Of course, you have to invite a team to come and what? Replace it. The ventilator tube is obstructed or when there are kinks, what you have to do is just unkink it as a nurse. If there's water in the tubing, please empty the water and that will take care of that. One of the things that can also cause these high pressure alarms to go off is when the client is coughing. When they are coughing, it also increases the resistance to the flow of air, and therefore the high pressure alarms will go off. When they are also gagging, biting on the tubing, this can also cause the high pressure alarms to go off. But the question, pay attention to what the question will say. Usually, they will tell you the reason why this high pressure alarms is going off. So, for example, you have a patient that is biting on it, and then they are restless, they becoming more agitated, and they are unconscious. This might be a sign that this patient is in pain. So, think about pain control. So, always pay attention to what is in the question before you start thinking about what you're going to do. That is why the people who are successful in English are not the one that can memorize. There's a lot of things that are there. You can't memorize all of them. But if you know what you have to do for a patient when you suspect or when they tell you in the question that, hey, this person is having a lot of secretions, then you have to know that no, at this point, it is not about personally breathing. I need to what? To do some kind of suctioning. I need to encourage the person to breathe. This time, those are the type of questions you should be expecting. When a client is anxious or frightened, please stay with them, reassure them, use therapeutic communication. If that is not going to work, then we can bring in some anxiety medication. We don't first start with medication, but medication is also another option that we can use. So that is mechanical ventilator for you. The next we're going to talk about is going to be the low pressure alarms. With the low pressure alarms, this is where we think that when there is a disconnection or there's a leak in the ventilator. That is why the low pressure alarm is going off. The best thing you can do is always to what? To reconnect. Now, I've seen questions where options are check the machine, check change the settings. You are dealing with a human being. Whenever a pressure alarm or whenever alarm goes off and you cannot figure out where the alarm is, best choice you have to do is to manually start ventilating the patient. And then later on you can figure out, because what is the use of you trying to figure out what the alarm is instead of taking care of your patient. And that is why we always have to get emergency or resuscitation equipment available at bedside at all time when you have a patient on ventilator or when you have a trach patient. Always remember the little things that we do is what saves our patients. Thank you for learning all the treatment options. The other ones I'm going to add to you, which I want you to remember, will be medications. You want to stay away from medications that will prevent coughing, especially when the person is having a productive cough. We want them to cough this secretion out, but if you give them cough suppressants like codeine, opioid, this is going to depress the coughing reflexes. And when that happens, you end up suctioning your patient. So stay away from that. What you should be looking for is medications that are going to break down the secretions. For example, you have mucinex or we have mucolytics. Mucolytics are medications that breaks down secretion. Anytime you hear mucus, lytic is breakdown. So mucolytics is breaking down mucus. One of the other interventions that we can put in place to help secretion is turning the patient if they are not able to turn. If they can walk, why not walk them? Exercise will help clear the secretion. Then make sure that when they are dehydrated, encourage fluid intake, especially when the person is not drinking a lot. We can even start IV fluids, but stay away from questions that says that give them bolus. Remember, we want to prevent. This is not a time of rescue. So you give them a maintenance dose of the fluids